Il est 7h02. Donc, à quelle heure on démarre?
ولكن راك ديزاكتيفي الميكرو ديالك.
OK. Bonjour tout le monde. Tout d'abord, je voudrais remercier tous les premiers présents parce que normalement, vous êtes plus de 200 inscrits à ce webinaire. Pour le moment, on est plus de 60. Donc, en attendant d'introduire le webinaire et puis le conférencier, je voudrais tout d'abord vous remercier pour votre présence et remercier en deuxième lieu notre partenaire officiel, Align Technologies, qui nous permet bien sûr d'animer ces webinaires. Donc aujourd'hui, nous avons le plaisir et l'honneur de recevoir le docteur Greco Alessandro Mario. Le docteur Greco est en pratique privée à Rome. Il est visiting professor à l'Université Ferrara. Il a aussi le board italien et le board européen. Aujourd'hui, il va nous traiter un sujet qui est assez important en orthodontie paraligneur, qui présente une problématique assez importante en pratique, c'est la gestion de la supraclusie. Vous savez très bien que autant on peut gérer la supraclusie plus ou moins avec une certaine maîtrise avec les systèmes classiques, les multi-attaches, ben avec les aligneurs, il y a une certaine subtilité qu'il va falloir connaître pour pouvoir les. So, Dr. Greco, thank you for accepting our invitation, and the floor is yours.
Thank you so much. Thank you so much, Dr. Benantar. It's a pleasure for me to be tonight together with you. So it's on a topic that I really like and I would say I love, because it's one of my favorite topics, talking about deep bite management with aligners. I would love, believe me, I would love to speak French with you, but unfortunately, I'm not able. I can understand words since the Latin root is the same, but definitely, unfortunately, I need to speak English if I want to give a sense to this hour we will spend together. So, for sure, this is one of the most interesting topic, because we know it is not really simple sometimes to treat the bite, but as well as we know that defining the ideal position of the upper incisor generically is a crucial point in the aesthetics. And this is why, because we know from some paper, this is one article published from some Italian friends, that generally the vertical position of the central incisor is considered like a key factor when we design the smile arc. And this is fundamental, because when we exceed in the intrusion, for example, we are making the upper incisor disappearing from the smile. And this can be a huge problem during our treatment plan. That's the reason why today, I think, with all the technology that we have available while doing our treatment plan, it will be really nice, not for, let's say, something that we are using with the patients to say, look at this is your smile before and after, and this is the huge modification, as we normally can see here, what we call in-phase modification. But what is really beautiful, in my opinion, is that we can really understand how much intrusion, for example, in a deep bite we have to plan without affecting negatively the smile arc, without affecting negatively the smile line, so the exposure of the gingiva in the front teeth and in the posterior. This is fundamental, as well as, of course, when we see the teeth moving inside the frame of the smile, we can really carefully define the midline together with the smile leg, together with the smile line. So this is something really fundamental. And today we have a further, let's call, control to understand this one. But of course, what is fundamental, and this is something that we learned. I'm working with Invisalign, with aligners, in particular with Invisalign now from 20 years. 21 years to be more specifically. I started in 2004 treating patients with aligners. And so we know really well one of the huge problem is determining the ideal leveling of the cavus-P when we treat patients with aligners. And this is something fundamental. But there is another fundamental things we need to think about, and is based on the biomechanics of the aligner itself. Let me jump back 1 second. We really know very well that the biomechanics of the aligner is different than biomechanics of conventional fixed system. And since we are talking about rigidity of a plastic material, we know that the rigidity will be really higher in the anterior part, will be mid force exerting in the middle, and will be really low force in the terminal part. This is why, because the elasticity of the material is maximum when we try to press from second molar to second molar. When we try to compress the plastic in the frontal area is more rigid. What does it mean? That the force we exert can be different. And for this reason, if you think about this kind of concept, we need to pay attention. When we try to define and extrude, for example, the posterior teeth, the second molar of 1 millimeter, we need to face the reality. This is really complex because of the large elasticity of the material can be different. This is the first consideration we have to think about. What about the second? Well, the second is represented by the inner features that we normally have with aligners, in particular with Invisalign aligners, the power reach. And we know this is a really nice concept, ideally. Why? Because we have in class 2 division 2 the need of procline the upper incisor, the need of exerting some torque expression. But in an ideal consideration, we can have one force from the buccal close to the gingival margin, one force exerted on the palatal side on the incisal edge, and this is creating a moment. This is when we have power ridges. This moment is exerting torque, but this happens normally in an ideal anatomical condition, an ideal morphology of the upper incisor. Is not always like that, because pretty commonly we see that we have patients with short clinical crown because of wearing, because of genetics. And so what happened? We have the power ridges, one in the buccal, one in the lingual, even only one on the buccal surface, which is pushing. But the moment created is too short, considering the unfavorable relationship between the roots and the crown. And for this reason, when we try to apply the force, we don't see torque, but we see an undesired intrusion. As you see from this picture, power ridges sometimes are in the middle of the crown. And for this reason, they are not doing their job. So it's not work. So in this kind of situation, it's better to remove power ridges and leave the plastic exert the torque, probably by some overcorrection. The ideal condition should be this one, as we can see here. So the power ridges should stay close to the gingival margin. This is the fundamental approach. And there is another situation we need to think about, that sometimes this kind of condition, let's say, this kind of position of the power ridges that cannot be set by ourselves, cannot be asked by technicians to change, is automatically placed by the software. So that means that in some situation like this one, as you see here, there is a difference in position between one and the other. And this is why, because it's the gingival margin affecting the position of the power ridge. When we have a U-shaped gingival margin, the power ridges is in the proper position. When we have a V-shaped gingival margin, unfortunately, the power ridges is more in the middle of the crown. In a situation like this one, is normally, again, is better to remove to avoid problems. And third, biomechanical consideration. When we have a class 2 division 2 and a deep bite, the most, let's say, predictable kind of protocol is represented by what is called PIR. So that means proclination, intrusion, and retraction. And this is why, because the opposite kind of protocol, which is the TIR, so talk, intrusion, retraction, the TIR is based on the roots, so it's slightly less predictable, I would say, less predictable. But the PIR is based on the first crown movement. So for this reason, can be way far more and more predictable. So we always need to think about this, about the PIR, which is fundamental. At this point, let's try to ask and try to answer some of the common questions. When we have a deep bite, what do we observe? Second, what do we diagnose? And third, which is fundamental, what do we treat? Let's try to reply these questions. First of all, we see a huge problem that we identify in an anterior problem because we don't see a normal overbite. We see a cavus P that can be really, really deep, and in an association with this one, an over eruption of the lower incisor that comes to touch on the palatal surface of the upper incisor. And sometimes we have also in some of the patients some missing molar, that means loss of vertical dimension. How can we diagnose this? Well, actually, on the lateral X-rays, most commonly. And we normally see a skeletal problem, like a skeletal pattern. At the same time, we can managing to see some reduced and really close gonial angle. And finally, which is the most common situation, we face an inclination of upper and lower incisor that can be really negative. And this is the huge problem that we normally see. How can we have an idea on how to fix, first of all, before treating? Let's try to see on literature what we found about deep bite. And there is a beautiful paper published in 2012, a really commonly cited, not only by me, but from many, many people, which is this one, which is analyzing the underlying components of the deep bite. The secondary are inclination, over-eruption, and vertical component. But the most fundamental components of this kind of malocclusion is represented by the cavus P and by the decreased gonial angle. This is pretty interesting because in this paper, they conclude telling us, well, since if our mechanics can be able to achieve 1 millimeter, only 1 millimeter of posterior extrusion, the bite can open by 2.5. And this is why, because the posterior extrusion is leading to a extrusion of the molar, that means a premature posterior contact that can be significantly open the bite anterior because of clockwise rotation of the mandible. This is pretty interesting because this paper is telling us that we normally, when we see a deep bite, we are focused on the frontal area. But the solution should come not only from the frontal area, but also from the posterior teeth. This is a really interesting and fundamental information apart from the tool that we decide to use. But the problem is this one. We know that the posterior extrusion with aligners is really complex because we have the thickness of the plastic. In fact, if we are going through literature and asking about solutions coming from Invisalign and, for example, in this case, Invisalign and deep bite, we found that in this paper, 2017, the only options was proclination of upper lower incisor. And this is why, because they were treating patients without, before, as you can see here, the introduction of the G5 protocol. The G5 protocol is represented by the bitrams, and they were not available. No bitrams, no correction of the malocclusion. More recently, another Italian group published a paper, and they say that the possibility of leveling the cavus P is just because of the proclination of the flaring of the incisor. But again, when we talk about bitrams, they say that this kind of auxiliary was impossible to use. So again, partial result, partial success, no bitrams used. Let me go further. I know this is not really the time to review literature, but just to give an idea, this is one of the most recent papers published, 2023, 2024. Same sample, two different papers, same group of authors. And as you can see, the result is that the accuracy of the deep bite correction is 33%, really, really super low. And this is really strange because honestly, I have a different kind of percentage. And if you ask why, the problem is always the same. They only few patients, only 7 out of 20, only 6 out of 24 were using bitrams. And in particular, only few patients were using class 2 elastics, which are fundamental. So we realized that from this kind of literature, if we don't use bitrams, we can't correct properly the deep bite with aligners. This is the reality. Why? Because on the opposite side, the only papers that are using bitrams, they say that there is a buccal extrusion of the posterior teeth, which is leading to a clockwise rotation of the mandible. Wow, this is interesting. And what happened if you look at one of the most recent paper? Same kind of things, same kind of information. When using and blending extrusion of the molar, this is resulting in a clockwise rotation of the mandible, which is exactly on the same line. But to achieve the posterior extrusion, we need bitrams, we need elastics, and we need a correction of the buccal, the posterior torque, as well as proper leveling of the cavus P. This is really interesting because all the literature is agree on this point. If you don't use bitrams, the correction can only be partial. So why don't using bitrams at this point? Because we can fix both situation, the frontal problem that we normally see, and we can give also a solution that can face and can achieve a proper inclination of the front teeth, as well as a proper extrusion of the posterior. So it's exactly in this position we need to focus. So how can we achieve this one? Well, let's say this one. First of all, what I want really to see is this one, is trying, since I'm using a system which is a sort of piece of wire, like an arch wire, I want to see a proper biomechanical balance. So if I'm applying an action for the incisor, I want to see a reaction in the posterior teeth. And to achieve this one, I need anchorage. I need attachments to achieve this one. How can I manage in this way this kind of balance? Well, first of all, I can try to express my torque, which is fundamental. So that means upper incisor proclination, as well as I need to procline the lower arch. I need to procline the lower incisor because I need to work on the arch length. And finally, I need to think about the posterior relative extrusion. These are the three fundamental points we need to think about anytime we are treating deep bite with aligners, because unless we can't be properly successful in treating the bite. So before showing you clinically, I want to really give you an idea on what I'm doing in all my deep bite patients. How can we manage talk expression? Well, we said before, PIR. I would say that in some patients, we can't manage to do retraction. So the R from retraction is something that is not always possible because sometimes we have patients that are really with a flat profile. So we need proclination and intrusion. So I would say PI. Imagine a situation like this, which is my reference. My reference is always the same. I identify the most anterior border of the maxilla, which is the anterior nasal spine. I draw a vertical line, and definitely if I need to procline as much as the upper incisor are touching this vertical line. This is why, because in this way, I can put in balance the anterior limit of the upper dentition with the anterior limit of the maxilla. And this is exactly what I 100% need if I want to achieve the proper talk expression. Of course, as I said, sometimes we don't need retraction. Even if when we are crowding, we don't need retraction. Number one. Number two, which is fundamental, we need to level the cavus P. But the cavus P, when it's really deep, is asking for space, is a request of space, leveling the cavus P, definitely. How can we do this? Well, again, we can identify the most anterior border of the mandible. We put a limit, like a vertical line passing for the Pogonian, and our anterior limit of the lower dentition would be this one, similar to the upper one. How can we understand if we are really doing a proper plan with aligners? Well, normally what I'm doing is superimposing. Blue is initial, white is the final. If I'm really proclining, I would see white in a more anterior point than the initial. And what about the even being more precise? Well, we have the ruler inside the software. So what we can do is measuring the arch length, placing 1 point mesial to 6, 1 point mesial to 4, distal to canine, mesial to incisor. We are measuring the arch length, and we know in numbers how much we are increasing. This is the only way to be sure that we are doing a proper leveling of the cavus P. Because in my opinion, this is the most sensitive topic about this. We cannot treat in a different way. This is the huge problem. Because if we don't consider the arch length, we can be never to a proper arch leveling. So, last but not least, we need to work on the posterior relative extrusion. So to do this, it's fundamental having bitrams. As literature said, we can't do a posterior relative or real or relative extrusion without bitrams. Why? Because bitrams is creating a huge disocclusion. This is the initial malocclusion and aligner number one. And we see this big posterior disocclusion. And this posterior disocclusion is maintaining constant from the beginning until the end of the treatment. Of course, bitrams has got a maximum extension of 3 millimeters, and they are not fixed in one position. They are moving. So they change position from gingival to more occlusal. And this is why, because since we are leveling and we are intruding, for example, the lower incisor, the bitrams will stay in contact with the incisor. The incisor are going down, the bitrams are going down. In this way, what happened? A couple of things that, in my opinion, are really fundamental. Number one, we keep constant the posterior disocclusion. Number two, even more interesting, our patient is biting 22 hours per day only on the bitrams. So we are redirecting the occlusal forces. That's the reason why they are so effective. This is, in my opinion, is the reason why I really believe if you want to treat properly, we need bite trams. There is no reason why we don't use bite trams. We just need to select which kind of bite trams, because we have two different kinds. The precision bite trams, the one placed on central and lateral incisor, and as we said, they change the position, and the canine bite trams. They are conventional bite trams, the one we place on canines. They are placed in a fixed position, so they don't change position. So why we use one or the other? In order to understand the biomechanical difference between bite trams on canines and bite trams on the incisor, we need to think about another inner feature of the aligner, which is called pressure area. The pressure area are a sort of depression of the aligner. So they can create this kind of depression to push more on the lingual surface of the incisor. And in this way, we can favor a more specific resultant intrusion of the incisor. Of course, unfortunately, pressure area are not really visible. So if you want to be sure that we have, what we can do is just using this kind of reapproximation form, which is telling us that with this circle that we have pressure area available for some specific incisor. And as you can see here, also canine in the lower. But of course, they are a depression of the plastic, while bite trams are an extension of the plastic. So for this reason, when we place bite trams on the incisor, we only have pressure area for the lower incisor. If you place bite trams on the upper canines, we have pressure area available also for the upper incisor. So they are conceptually different. They are not the same. So we don't place bite trams on canines and incisor because they are the same. There is a biomechanical conceptual difference between these two kinds of approach. And which is this kind of difference? Well, it depends on where we want to intrude, definitely. And this is, of course, is related to the smile. When I have a patient with a really proper smile arc, for example, my intrusion will be focused in the lower jaw, in the lower arch. For this reason, I'm going to place bite trams on the incisors. When instead I see a gum smile, which is typical, also this one, in when we treat deep bite, I will put bite trams on canines. Why? Because in this way, I will have available the pressure area for the upper incisor. And that means that I will exert more intrusive force in the upper. So definitely we define if using bite trams on canines or on incisor, following the smile arc, following the smile of the patients, if we have a proper exposure or if we don't. At this point, we can choose to use one or the other following the way in which the patient is smiling. This is fundamental. And finally, we need to plan in our digital approach the proper leveling of the cavus P. This is something not really probably easy to do it, but if you try to really carefully listen, you will see that it's not so much complex. What I'm doing personally, first of all, just to let you know, this is something I do manually. I do by using 3D controls. So I'm not asking designers or technicians to do it for me. I do by myself, as all the modifications. Nowadays, I don't text to the technicians anymore. I use 3D controls. I use some other tools that we have available, like Plan Editor, for example, and I try to manage everything by myself. So in this way, I can approve immediately a treatment plan without sending a modification and then waiting for a new clean check to come. So for this reason, what I'm using to level properly the cavus P. Well, this is my cavus P, really deep. what I'm trying to do? I'm trying to use the second molar as a reference. What does it mean? The second molar is a reference that I'm not extruding. Why? I told you before, because this is the area of maximum flexibility of the aligner. So for this reason, I'm not going to extrude the second molar. While what I'm doing, I'm going to extrude the 6 and the 5 and intruding from canine to canine and sometimes also the premolar. So the first premolar is in the middle, so it depends. So what does it mean? This is the vertical dimension of the leveling of the cavus P, dimension number 1. On the vertical dimension, I'm not doing any pure extrusion of the second molar. I'm just doing pure extrusion of 6, 5, and intrusion of the rest. Dimension number 1. Dimension number 2, sagittal. What I'm doing on the sagittal dimension, I'm creating a sort of ideal leveling of the cavus P, like if I'm using an arch Y. And what happens if I'm using an arch Y? I see this. I see action, which is proclining incisor, is tipping mesially canine and premolars, and on the opposite side is tipping distal 7 and 6. Why I'm doing this? Because this is more natural. And what happened to the second molar that I didn't extrude purely? I'm doing a distal tipping, which is a relative extrusion. This is exactly my goal, is trying for the posterior teeth to combine a pure extrusion with a relative extrusion in the 3 dimensions of the space. In all of the 3 dimensions, because this is the second dimension, sagittal. What I'm doing on the third dimension, which is transverse. Well, in the transverse, I'm trying to do what the literature is trying to highlight. Let's call a buccal extrusion. Why? Because I'm changing the torque. I'm changing the torque. I'm not doing a bodily expansion, which is not in nature. I'm correcting the torque, and I'm trying to give on my clean check a correction, which is an uprighting of the posterior sector, which is moving the buccal cusp in a more extruded position, and this should be close to 0 degrees. Why I'm doing this? Because in this way, I'm putting the buccal cusp in the position in which they will extrude and they will create the premature contact. Remember the literature I was showing to you before. The literature is telling us 1 millimeter of posterior extrusion, 2.5 change in the overbite. So I'm looking for that millimeter. So what does it mean? That I can do the posterior correction by moving the crown in a more buccal position and creating a posterior premature contact. I don't need so much. I need definitely 0.6, 0.7 in the lower, 0.6, 0.7 in the upper. I need the bitrams to have the posterior disocclusion, and that is done. Okay? So this is exactly the way in which I'm blending. And at this point, what happened? At this point, I would say this kind of configuration is generating 3 different clinical conditions, 3 different clinical scenarios. The number 1, I have a patients with deep bite and gummy smile. Okay, so I need upper intrusion. For this reason, I will use bitrams on canines. And this has allowed me to apply pressure area for the upper incisor to fix the deep bite. Clinical condition number 1. Clinical condition number 2. I have patients with a proper exposure of the smile. The cavus P is really, really deep, so I want to level. I want to intrude in the lower, and for this reason, I'm using bitrams on incisor, upper, central, and lateral. in this way, since the exposure is proper, I will use the bitrams to intrude in the lower and leveling the cavosp. Clinical condition number 3, which is probably a little bit less common, but even more interesting, I would say, in which we decide in some situation to postpone the bitrams. So not avoiding the use, but postpone. And why we normally postpone the bitrams? For a couple of situations. Number one, when there is too much overjet, and so of course the bitrams in the incisor are not touching, or when we have a really negative inclination of the upper incisor. So that means that they are completely retroclined. In order to give you a reference in terms of number, I would say that upper incisor on the maxillary plane measures less than 90 degrees. If we have less than 90 degrees, that means equal to 90 or less, that we need to postpone the bitrams. Why? Because the occlusal forces biting in this kind of inclination can create can affect negatively the proclination. So we first procline, as you can see in this video, we first procline, and then we ask technicians to customize the bitrams and place bitrams during the treatment. For example, after exerting 15 degrees of torque, 10 degrees of torque. So that means more or less 10 or 15 aligners. This is the way in which I'm trying to divide the plan of the deep bite. I'm really sorry because I normally, this took me a half day to try to explain. I'm trying to do in 1 hour, but this is exactly what I'm doing all the time in which I'm treating a deep bite. How does it work clinically? Let me show you a clinical case which is really following what I told you right now. This is a young teenager, beautiful girl with gummy smile. So when I have gummy smile and deep bite, like in this case, no choice. We need to use 100% bitrams on canines. I have a subdivision, class 1, more or less class 1 on the right, even if not perfect, and class 2 on the left. Some spacing in the lower, a not beautiful arch shape with mesially rotated molars, and a genesis of third molars, and this is probably the reason why we have spacing in the lower jaw. And in particular, when we look at the cavosp, not in the lower, but in the upper, we see an over-extrusion of the incisor. If you are going to measure on the lateral X-rays, we found a skeletal class 2 malocclusion with more or less 5 degrees of A and B, so not really severe, 2 millimeters of width, and as you can see, an hypodivergent facial pattern. Okay, this is pretty common, let's say, to me. This is pretty common. And with all of this kind of problem, I know what to do. Why? Because first of all, it's a subdivision. I want to fix the class 2, but the midline is really centered in the philtrum. So that means that I cannot distalize in the upper. I need to mesialize in the lower, and I will do it. I will do intrusion of the upper incisor, and as always, in all of my deep bite treatment, I'm using class 2 short elastics. What does it mean short? From the first molar to the first premolar. More vertical, and I can easily manage to generate a more vertical extrusion to control finally the correction. Remember this, if you think that they are too short from first molar to first premolar, don't forget we have bitrams. So the patient is not biting on the teeth, he's biting on the bitrams. That means that the distance from first premolar to first molar is definitely higher and is more vertical, which is exactly what we need. I'm using, as you see, palatal attachments, which is typical, peculiar of my personal approach. And I'm doing expansion and creating definitely strong occlusal contacts. And this is why, because I want to see posterior, relative, and real extrusion to generate the proper correction in deep bite. How long is this treatment plan? Well, we are talking about 30 aligners, more or less, to create this kind of correction. I'm sorry. That's the reason why we see in 29 aligners expansion with distal rotation of the maxillary molars, the use of bite traps on canines, and finally the proper leveling of the cavus P. Look at this. This is really something I'm doing as a trick, let's say. Since I'm leveling the cavus P and I want to mesialize, I will use class 2 elastics also to support the visualization, but pretty commonly, I'm not moving the second molars. I'm using second molars as an anchorage point. Of course, that means that in a further stage, I need to think about the closure. But normally, when I'm planning this kind of approach, I'm opening a space between 6 and 7. And then when I see that they are in a proper position, the mandibular molar, I cut the aligner distal to the 6 and I leave the second molar come spontaneously forward, which is something I normally see all the time because mesialization is in nature. And this is a big advantage. And in particular, this kind of movement of mesialization is a sort of relapse. Look at what happened. 29 aligners, and this is the correction of the deep bite. Interesting, still not enough, however, still not enough. And in particular, we are in a more precise, let's see the difference, class 1 occlusion, but still not ideal. The expansion in the upper is pretty good. The space opening between 6 and 7, as you see, is really reliable without excessive mesial tipping, but we still need to open the bite. So I need other 20 aligners during the additional, in which I'm focusing more in the intrusion of the upper incisor, as you can see here. You see that I'm not still correcting the position of the second molar. I'm still using a continuous aligner with a space between 6 and 7, as you see here. So still continue in working and creating again strong occlusal contacts. And this is what happened at stage number 20. You see in this way a nice correction, a class 1 on both sides. At this point, I need to cut the position, cut the aligner distal to the first molar and favoring a spontaneous mesialization of the second molar. This is something that I know can work. I know really well. So that's the reason why. Let me show you some picture of the face at the end, and even better, the X-rays showing the full mesialization of the second molar without doing anything special, but just cutting the aligner. This is something I do commonly. It's something I call lock and move, and I found really interesting. As you see here, this is the value at the beginning, and look at the end. Look at the FMA. I see from 26 to 28. This is pretty interesting because the bitrams can allow you to see a clockwise rotation of the mandible with a really nice change. You see the torque correction of the upper, you see the leveling of the cavus P, and when we try to superimpose, we see these 2 degrees of clockwise rotation. That, of course, is not ideal in a class 2, but we can compensate more with some dental movement. And that's the reason why we see some distal rotation with some of the maxillary molars and mesialization of the lower molars. This is something that I normally plan in Gummy Smile, and I see a really nice correction, like in this case. Look at the overlapping at the beginning of upper incisor on the lower and what happened at the end. But pay attention. This is the, let's say, relationship between before and after. Still not perfect in my idea. Why? Because it's changing nicely dental, the correction, even as we see here, close to my digital plan. But when I look at the face of this patient, when I look at the smile, I spent 1 year, I don't see this kind of huge correction of the gummy smile. It seems to be closer. But if you look a little bit more closer at this picture, we see that upper incisors seems to be shorter. And this is why, because we push into the bone. And that's the reason why probably still, as you can see here, the gingival margin is not really fully achieved a maturation. So when we try to probe with a probe, we see an excess. The CJ is in a more higher position. So for this reason, this is what I'm doing when the patients, of course, grow a little bit more in order to leave the gingival margin the possibility to develop. I'm doing a laser gingivectomy. And this is what happened, as you can see, in a slight long-term control in which we have space completely closed between 6 and 7, a nice class 1 occlusion, and a proper correction of deep bite, and a proper correction of the gummy smile. This is the girl in which at the end we see a different smile, which is really amazing because finally, if we remove this excess of gingiva, we see a nice development on a proper smile arc and a proper smile line, as I said at the beginning. So not only smile arc, but also smile line. This is pretty nice, but it's something that can work only in teenager. I don't think so. And for example, when I'm facing an adult patient with a really deep bite, but in this case, I would say easier because it's a class 1, I know I can treat this in a really super easy way. You see that the cavus P, which is deep in the lower in this case, when you look at the exposure of the smile, the upper incisor seems to be in the proper position. When we look at the lateral X-rays, we are facing hypodivergent skeletal pattern. This is, again, more similar to a class 3 than to a class 2 in this case. But the correction, the treatment plan for me is always the same. So what I'm doing is using short elastics, expanding, leveling, proclining, and using bitrams in this case from the beginning. Why? Because if I go back to the inclination of the upper incisor, you see that they are 100 and some. They are not less than 90. I don't need to postpone. The lateral X-rays is telling me 110. So that means that I can start immediately with bitrams. And I only have 17 aligners. Adult patients, in this case, around 40. And we see only 17 aligners in the lower and even less 12 in the upper. You see always the distal rotation, which for me is fundamental, the use of bitrams and the combined use of short elastics, which is fundamental. And after 17 aligners, this is the correction. You see the correction of the debut with a really nice posterior intercuspation. Why? Because of the elastics, because of the bitrams and because of the elastics. Beautiful. It's still not perfect. I need to refine some alignment. So 5 aligners more. This is beautiful. 17 plus 5, 22 aligners in total. I'm refining the alignment. I'm refining the intercuspation. You see that during my additional, a lot of teeth are gray, so I'm not moving. I keep in the same position, and I'm just improving and increasing the proper interproximal contact, improving the alignment, and then I'm going to finish, okay? As you see, nice intercuspation, super fast treatment, no change in the position of the upper incisor. I need initial same amazing smile with a really nice correction, as you can see from this picture. Is this consonant with my digital plan? I would say Yes, as you can see, I don't plan any overcorrection in the digital when I'm using this kind of approach I described to you. So Bytrams does not require any over engineering, in my opinion. This is the change between before and after. You see the leveling of the cutoff speed, which is really nice, completely flat at the end. And what happened on the lateral X-rays? We see here small proclination of the upper incisor, a little bit more proclination of the lower, and look at the FMA, only 1 degree, but however, 1 degree of clockwise rotation. We just need 1 millimeter of posterior extrusion to see this kind of light clockwise rotation. As we can see, in the general superimposition, sorry, at the end of the treatment. Let me show you the morphing, which is analyzing this, which is really interesting. Now I just need to keep stable by using retention and 2 years follow-up. This is the situation. Still absolutely stable. What happened? 5 years, 4 years follow-up, still stable. Not ideally, but still stable. Always using the same kind of approach. In the last 6 minutes, let me show you the last situation, the one in which we postpone the Bytrams. Why we postpone the Bytrams? Well, because in some situation, in a really short phase like this one, which is a surgical problem, as you can see from this profile, this patient has got a surgical hypodivergent patient. We have a class 2 subdivision, class 1 on this side, class 2 on the right, super crowded condition, really deep cavosp, even worse than before. So again, when I see this kind of patient, I have no doubt. Bytrams on central and lateral incisor. Ideally, this is should be treated by a surgical approach, but this guy refused any kind of surgical solution. So my goal was trying to achieve a correction. As you can see, the hypodivergent condition is really severe, 7 degrees by FMA. And when you see the widths, we are facing a really severe skeletal class 2 malocclusion. So in this kind of situation, you would say, I'm going to change something. No, I'm going to do exactly the same kind of protocol. Leveling the cavosp, 3 points, talk expression, arch length increase in the lower jaw, and posterior, relative, and real, and pure, extrusion. That's it. No change at all. Same kind of use of elastics, to level the cavosp, to get some torque 0 degrees expansion. And in this case, since the upper incisor are really negative, less than 90 on the maxillary plane, I'm using Bytrams in a postponed condition. You see the amount, how the system is imbalanced in the lower, intrusion in the front, extrusion in the posterior, and elastics in a short configuration. I have 44 aligners. Why? Because we have a class 2 subdivision. The midline is fine. I cannot distalize. I can only distal rotate the molar. And again, what I'm doing is mesializing everything. Sorry. Short class 2 elastics, PI protocol, proclination, intrusion. And the Bytrams are there from stage number 15, not before, 15. So the first 14 aligners is without Bytrams. Ideally, each aligner is exerting 1 degree. Ideally, in 14 aligners, I can exert 14 degrees of correction, which is enough. I will use elastics on the first premolar, as I said, using no power ridges, and for this reason, I'm doing an over correction in the talk, not in the bite correction. Only in the talk expression of the upper, I'm using an over engineering. You see also a huge rotation of this premolar, and look at how natural looks the leveling. Look natural. This is the key. All the clean checks should look natural and logical. even though, as you can see, we have a lot and a huge amount of proclination and intrusion. But if you plan proclination with intrusion, this will work because the proclination is a relative intrusion. In fact, this is what happened. Few months in treatment, look at how the deep bite is changing. And this has happened when we arrive at the last stage, number 44. You see here, nice midline correction, bite opening, fully aligned, full class 1 on both sides. Even not beautiful teeth shape, unfortunately, but as you can see, all the rest seems to be really, really fully addressed. Is this different from my digital? I would say absolutely not. So the superimposition between real and digital is really, really super close, as you can see from this picture. And there is no overcorrection in the deep bite. I'm not planning an open bite to treat a deep bite as someone is doing. But I'm using always bite ramps. And you see what happened when I'm using bite ramps. I was proclining a lot. I agree with you, seems to be a lot. But generally, if I draw my vertical line and still the lower incisor is under control, I'm relaxed. You see the amount of proclination of the upper, and again, a slight 1 degree. This is a surgical deep bite, 1 degree of clockwise rotation, which is leading to this big change in the inclination of upper incisor, lower incisor with a slight clockwise rotation of the mandible. This is something that as I said, is I don't like the word protocol, but this is my personal protocol, which honestly at the moment seems to work pretty nice in all the deep bite malocclusion. I'm collecting some patients for this reason, and we are trying to set up a really nice, I hope, a really nice research. So remember, this is at the 3 question. We try to give an answer. And the fundamental message is don't be focused only in the front, because unless it's not working. We need to give an answer that comes from the front as well as of the posterior teeth. So that means proclining the incisor with a PI approach, creating the relative extrusion that is coming from the expansion and from the distal tipping, fundamentally. Creating strong contacts, this is fundamental because we don't want to see any intrusion. We need to plan extrusion. And to support this kind of posterior extrusion, we need elastics, short class 2. This can generate that kind of clockwise rotation of the mandible, which is 100% fundamental. If you liked this lecture, we are going to the end. I will just share with you one of the of my paper I published in 2021 on the Journal of Orthodontics, which is exactly explaining how to do the proper leveling of the Cavos P. So if you're curious, you can use your camera and to just take this QR code, and automatically this paper will be downloaded, the PDF that you can read in any time you want. And this can be probably useful for you just to have a recap of this really short lecture. It's 9.1 minutes, so I would say perfectly on time, which is absolutely not common from an Italian. I can kindly thank you for your attention.
Thank you very much, Dr. Greco, for all this valuable information, and also for your didactic way to explain all details about the special topics and the difficult topics with to correct deep bite with aligner. It's not a simple issue. So we have 2 questions.
Okay.
From the assistant. Can we distalize with bite ramps in class 2?
Okay. This is an interesting question. I would say this. Honestly, sometimes can be helpful, let's say, because if you create a posterior disocclusion, the maxillary molars are not in contact, and that means that we can distalize. But however, as soon as we distalize, we will see, unfortunately, a reaction forces on the anterior teeth. So what does it mean? We push distal, but we have a reaction of the anterior forces unavoidably. So we need elastics. And for this reason, the bitrams can work not properly at 100%, I would say. I will take care about this. And as I said before, sometimes one of the best condition is trying to postpone. Is trying to postpone. This is the best in my goal. So first distalize and then asking, for example, to use bitrams in a further stage of the treatment, not from the beginning.
So, second question, how do you control the tip of the lower 7? It's an important question. How do you control the tip of the lower 7 when you rely on the
mesialization? Well, really, really nice question, but I have a nice answer. So I would say, yeah, this is a really fundamental question. And honestly, this is something I'm trying to control with an over correction, let's say an over engineering process. The over engineering process is this one. I mesialize, I don't know, 2 millimeters, let's say the second, the 6 more than the 7, I would say. And at this point, I would love to see a counterclockwise, a counter-tipping inclination on the. I'm talking about the first molar. I will tell you now the second. But first of all, the first molar is moving mesial 2 millimeter. So for each millimeter, I try to give at least 2 degrees of counter-tipping. So that means 2 millimeter mesial, 4 degrees of crown distal tipping. This is fundamental. What happened to the 7? Why I don't? I'm not so scared about the tip. Because when I make unmovable the 7, the second molar, in the reality, I make a movable on the digital. But what happened in the real is that the second molar is not in the same clinical position. If I push mesial the 6, the 7 will feel the reaction and will tip distal. So what happened when I cut the aligner distal to the 6 is so fast, this kind of space closure. First of all, because mesialization is in nature. Second, because we have a relapse. This is the reality. We have relapse from a distal tipping. So what happened that the second come mesial really fast because we have a relapse and we don't have to manage the problem. Because when you make some teeth unmovable on the digital, it doesn't mean it will stay unmovable in the real. This is the reality. In the real, they will feel the reaction from the pressure, from the force which is mesializing the 6. They will feel reaction by distal tipping. So what happened when you cut? They feel and close parallel in the proper position.
So the reaction is when you move, when you mesialize the first molar, we have a reaction mesialization of the second molar.
That's completely happen. If I didn't put some pictures, but I have some really nice documentation showing you on the X-rays how it happens. That we see second molar really distally tip.
Is it similar that what
Like
we usually use with fixed appliances when we have, for example, second molar extracted, so second premolar extracted, and we tip the first molar at the end of the treatment, and we have natural movement or.
It's like the famous tweet recovery phase. No, we try to prepare the anchorage like in tweet, and then we see the second molar really tip distal. Then we completely, as tweet said, we forgot about the second molar, and they come in occlusion.
But you cut your aligners. It's clear that you must cut the aligners.
I need to cut the aligners. Yeah, of course, I need to do this.
Okay, another question. I have one of my colleague who qualify your presentation, and it's a very good presentation. So congratulations to Michael. And we have another question about adult. What about adult with absence of lower molars? Well, if you have a deep bite without molars, I think we some auxiliaries.
We can do miracles, no? We can do miracles. We try our best. So if we don't have a molar, that would be really difficult.
So how do you avoid extrusion on the second molar since you cut the aligner?
Well, I don't want to avoid extrusion of the second molar when I cut the aligner. First of all, because I'm treating a deep bite. So if I have a slight extrusion, I'm fine with this. And generally, the premature contacts is really a problem when you cut both upper and lower aligners. But when you cut only the lower, that there will be an extrusion of the plastic, which is 0.75. So it's less than 1 millimeter. So I'm not really worried about this. But in the real world can be a beneficial approach, because if I extrude a bit, you can continue have a small correction of the deep bite. So it's not so bad.
When having bite ramps on the upper canine, do you prefer to place them directly on the canines or to be integrated in the aligner?
No, the bite ramps are normally like, to prefer to place them directly on the canines or to be integrated into the aligners? No, they are only on the aligner, so it's just plastic. It's just plastic, so I don't place any composite in it. So of course that means that is like empty attachments. When you have the one on canine, they are fixed in the same position, they don't change. So they are like a conventional attachment, no more. This is the
same participant asked as if it is possible to be quick and to repeat the question, to repeat the answer about the mesialization of the second molar after cutting the liner.
Yeah. So normally, when do you cut the aligners distal to first molar? I do when I see that the first molar is in the proper position, of course, no? And generally at this point, I can cut distal and I see that the second molar is moving completely in the following for, I would say, for 3 reasons again. One, first of all, is because mesialization is in nature. Second, the transeptal fibers, when you move the first molar mesial, they will pull the second molar in position. And third, because as we said before, making a movable in the digital doesn't mean that they stay fixed in the same position in the real. So it would be a relapse, definitely. And this is the reason why it works so nice. I have a lot of experience on this, honestly, in particular in asymmetrical class 2 subdivision, that I do a lot of mesialization. And mesialization is something that works pretty fine because it's really more following the nature than distalization for sure.
3 quick, short questions,
Yeah.
Greco. Attachment on premolars, is it your way to solve some problems, or you have some tips to share with us?
Attachment on premolars?
Yes. In lingual, I saw in lingual.
Yeah. I only use on lingual, and for me there is a specific reason, which is not aesthetics like people think. It's more based on the biomechanics, and this is why, because as I said before, my expansion is never a bodily expansion. I don't rely on bodily expansion, honestly. I don't think it's in nature. So the only thing I'm doing is a torque correction. So when you have premolars negative like this and you place vertical in a torque 0, like should be, and you have attachments from the palatal, you have the grip exactly where you need. So for this reason, in my opinion, they work better than buccal attachments, honestly, because the expansion comes and creates the proper torque correction.
When you have when you want to do extrusion and intrusion, do you have more or less a percentage at the end of the results about extrusion and intrusion?
Mm-hmm.
We have a lot of coverage posteriorly and we have occlusion. So what is the percentage about extrusion and what is the percentage of intrusion?
Okay, so well, this is something interesting, but for sure the percentage of posterior extrusion is not so big. But as we said, because
extrusion is not so big.
Of posterior extrusion is not so big because it's difficult. But as we said, we just need 1 millimeter. And if you divide the millimeter for 2 different arches, upper and lower, so it becomes 0.6, no, upper 0.6, lower. So this is manageable in combination with elastics, however, because without elastics, I don't think we can really achieve anything special.
You postpone the patterns in some cases with a severe lingual tipping side. Because I think it's the same like a lingual, because you want to avoid at the beginning forces, vertical forces that will torque more, and
this is
the same effect.
Same effect, absolutely same effect. I found really more useful to plan in this way because it's more natural. Simply, it's more natural. It's more how the teeth behave, let's say, under the force. It can be coming from lingual, can coming from aligners, but it's really similar.
Two last questions. Will the approach to be the same if we apply TATs to resolve the supraclusion?
I need to be really honest. No, I'm always try to be honest when I'm lecturing as a person, let's say, in my daily life. I am a big fan of tats, a really big fan of tats. At the moment, I'm writing a chapter on clear aligners and tats in the book of Professor J. Park, so I'm really honored of this. But to be really honest, when I say never, I really believe me, is never use a tat to fix a deep bite problem with a liner. Until now, at least I don't know. But at the moment, I'm using a lot of tats, but not for the correction, for the intrusion of the incisor. Because I believe intrusion is something that works pretty nice with aligners. Sometimes even when you don't want intrusion, you see intrusion. So intrusion is something which is completely embedded in the nature of the aligner.
One last question. I understand really the first part of the question. Thank you for your great presentation. Do you add all bite ramps in the aligners or only those of canines?
No, probably there was a confusion. So bite ramps on canines or on incisor are always empty. So there is no composite. So I'm not adding any composite. So generally I prefer to use one or the other following this kind of biomechanical difference. But no more, let's say. If we daylight position better with traveling patients. No. Traveling patients, I don't really understand.
Thank you very much, Dr. Greco. Thank you 2 times because I didn't have the chance to thank you for coming to Morocco 2 years ago, our annual meeting. It was really a pleasure to have you with us in Morocco. Hope to see you soon, another time in Morocco.
It's always my pleasure coming Morocco because it's a country I love. So thanks to you for your invitation 2 years ago and tonight. So it really, I always enjoy spending time with all of you. Thanks a lot.
Avant de terminer, je voudrais encore une fois remercier tous les participants à ce webinaire. En votre nom, je remercie le Dr. Greco d'avoir partagé avec nous l'ensemble de ces informations et surtout aussi ne pas oublier notre partenaire officiel, Align Technologies, qui nous aide et qui nous soutient toujours pour essayer de continuer à apprendre et à partager des connaissances avec des conférenciers aussi bien nationaux qu'internationaux. Thank you very much, Dr. Greco, and see you soon.
Thank you. I hope so. Ciao. Good night.
S'il vous plaît, si vous êtes toujours là, on vous demande la gentillesse de remplir le formulaire, le sondage que nous a préparé les organisateurs pour qu'on puisse avoir votre feedback, pour qu'on puisse aussi améliorer notre organisation, mais aussi le contenu des choix qu'on fait de nos webinaires. Merci beaucoup pour votre participation et prenez 2 minutes pour répondre à ce questionnaire. Merci beaucoup. Donc, on a apparemment terminé. Donc, encore une fois, merci beaucoup pour votre participation et on vous donne rendez-vous très prochainement à la rentrée, juste après les vacances, pour d'autres événements. Merci beaucoup.